The management of type 2 diabetes. Glycemic management through approaches that provide the efficacy to achieve goals, very high dose glutide, semaglutide, terrified, insulin combination, oral combination injections, GLP-1 receptor agonist, insulin, high GLP-1 receptor agonist, intermediate DP4 inhibitors. Insulin classified into three types based on generation: human insulin, modern insulin, and new generation insulin. Based on action, bolus insulin, short action, basal insulin, long acting, and ultra long acting. Combination pre-mixed insulin and post-mixed formulation. These are different types of insulin. Rapid acting insulin, Lispro, Aspart, Glucid have very short peak and short duration of action and short half-life. Ultra long acting insulin, Deglutide, has long half-life, about 42 hours. Pharmacological difference between insulin co-formulation and pre-mixed insulin involves mixing two biologically active solutions together in a fixed ratio combination. Insulin deglutide and insulin aspart mimics physiological insulin secretion closely, avoid the short-term effect and variability of contaminated pre-mixed insulin, thereby reducing the risk of hypoglycemia. Simplify the insulin regime without requiring resuscitation and lower the injection burden. Premixes involves the suspension of one biologically active solution with an insoluble biological inactive precipitate in a fixed ratio combination, biphasic human insulin and contaminated insulin aspart. Limitation of premixed insulin due to proteination, variability in glucose control, incomplete 24-hour basal coverage, need for resuspension. Moving beyond HbA1c, diabetic management, time in range, and glycemic variability. What is glycemic variability? Professor Buhsck has already elaborated. It is fluctuation of glucose and other related parameters of glucose homeostasis over a given interval of time. Consequences of glucose variability: hypoglycemia, microvascular complications, macrovascular complications, and affects quality of life. Lower day-to-day variability in glucose lowering effect for deglutide versus glargine. This is effect of deglutide has same variability, very low variability. Whereas with glargine 100 and glargine 300, there is very high variability. Glucose variability predicts risk of hypoglycemia. There are a lot of peaks and troughs. So hypoglycemia is also dangerous, not hyperglycemia. With glargine, there are many hypoglycemic effects, whereas with deglutide, there are low hypoglycemic effect. What is time in range? Time in range refers to time spent in the individual target glucose range 70 to 180 milligram, but occasionally 70 to 140 milligram. Percentage of time spent below range or above time range indicate hypo or hyperglycemia respectively. Time in range may be used as an appropriate endpoint in clinical research and as measures of glycemic control in patients with diabetes. Emerging evidence suggests that time in range is inversely correlated to the risk of developing microvascular and macrovascular complications in patients with diabetes. There are many cases of 7% A1C. This is very much variability, very high peaks and very low peaks. 40% in range, 40% high, and 20% low. This is low peak, high peaks and low curve. 5% low, 70% in range, and 2 to 25% high. Whereas there is no high and no peak curve, no peaks and no curve, 100% in range. co-formulation of insulin diluted with insulin aspart 30% and insulin diluted 70%. In the co-formulation, IDEC and aspart insulin diluted 70% and insulin aspart 30% existing separately in one formulation. In the subcutaneous depot, IDEC and aspart insulin co-formulation, it separates into different diaxamers and hexamers injected in subcutaneous tissue. Phenol diffuses quickly and IDEC and diaxamers linked up via single side chain with contact to form long multi-hexers. The short acting releases immediately and the long acting releases very slowly. Innovation to overcome barriers to basal bolus therapy, pre-mixed insulin, need for resuscitation, shorter duration of action, greater glycemic variability, shoulder effect. Whereas in co-formulation, 2 anti-hyperglycemic drugs in single formulation, simple insulin release 2 injections, greater flexibility in dosing timing, insulin only formulation, insulin diluted and insulin aspart. This is the pharmacological characteristics of IDEC. I skip this slide. Clinical use of IDEC and aspart in control on oral anti-diabetic, other basal insulin, premix or basal insulin, hypoglycemia with other insulin, multiple injections, lack of flexibility are barriers to glycemic control. Children above 2 years, adults and elderly with type 1 and type 2 can be given IDEC and aspart. Elderly patients with irregular lifestyle. Suggested once weekly titration is scheduled for IDEC in type 2 at individualized target maintain dose, at above target increase 2 units, and if below target decrease 2 units. Thank you.
Ladies and gentlemen, I now request Surgeon Commodore Sameer Sahirami, Head of Department Ophthalmology, to diabetes mellitus associated eye diseases. Ladies and gentlemen, give a big hand for Dr. Sameer.
So we all heard about how diabetes is becoming an epidemic, and today my talk will be about how this epidemic is affecting the human life. How does it evolve? What changes it causes? How we can manage it? And that right now. On the right is, on the left side, you can see how a normal person perceives the world. On the right, you see what happens when the diabetes affects the eye. You can see how it affects his vision. This is just to dramatize the fact that diabetic retinopathy is one of the most important problems which is yet to be recognized and given its place. Now, I think these figures have been given that diabetes is spreading as an epidemic. 33 million diabetics are in Pakistan, which is the third highest. And what is important here is that between a quarter to half of them will eventually develop retinopathy, which is the eye disease. So that is what is the aim of my talk, to make you realize that when we look at the diabetic, we should also look at the eye. It is one of the most underdiagnosed diseases. You can understand that nobody looks at the eye And we conducted a study where we found that almost half the medical specialists did not bother to check the eye. And you would be surprised that even 9% of ophthalmologists did not pay attention that they should have done. What are the risk factors? The most important is the duration of the diabetes. The longer the diabetes is, the greater is the risk of diabetic retinopathy. A person who is diagnosed with diabetes at the age of 30, in 10 years and 30 years time, 90% will have that retinopathy. Then there is the poor control, which is the HbA1c, and the hypertension, which needs to be controlled. What is the pathogenesis? Basically, it's a microvascular disease in which the high blood sugar levels goes to secondary level, leading to ischemia in the retina, and the retina responds by secreting vascular endothelial growth factors to increase the blood vessels. And those blood vessels, which are the new blood vessels, they are friable and they rupture, causing hemorrhage. What are the signs of diabetic retinopathy? The earliest signs are microaneurysms, which are outpouching of the capillaries, and there is a breakdown of retinal barrier with release of proteins and cells. This is an angiogram showing the microaneurysms. These are the microaneurysms. The other signs are hemorrhages, and as the disease increases, this is hemorrhages in the retina, and as the disease increases, the number of hemorrhages also increases. Then you have the exudates, which are basically lipoprotein or macrophages filled with lipids. They are yellowish in color, and they are seen in the retina. And then you have the cotton wool spots. They are whitish, fluffy, just like a cotton ball fiber, and they show the accumulation of neurons within the retinal fiber. How do you investigate diabetes? The two major investigations are optical coherence tomography, in which we measure the thickness of the retina, and second is the fundus angiography, in which we see how retina is, how good is the perfusion or any leakage. Now this is a normal optical coherence tomogram, and you can see the macula. This is the retinal pigment epithelial layer. Now what happens in diabetes is, for example, there is development of diabetic macular edema, and you can see the effect that is shown in the optical coherence tomogram. The other investigation is the fundus fluorescein angiography. Like any angiography, we inject the dye, which is fluorescein here, and then we see the progress of the dye. You can see the dye is filling the blood vessels. And this is a normal angiogram. This is the macular area, this is the optic nerve head, and you can see that it has filled very nicely. So there is no leakage, no hypoplasy. Now here you see that there is a massive leakage of fluorescein at the level of the optic disc. So this shows the presence of new blood vessels. Now how do we monitor the progress of the disease from very mild to very severe? So we, based on ETDR study, we have developed a classification into non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and then advanced diabetic eye disease. Macular involvement is in the form of clinically significant macular edema. Now, what is a mild non-proliferative diabetic retinopathy? Here you can see a normal retina. These thick are the veins, and the smaller ones are the arteries. This is the macular area. There is no problem here. But here, you can see there are aneurysms, there are hemorrhages, and exudates. This is a fundus photograph. You can see these thick ones are the veins, these are the veins, and these are the arteries. So the veins are, this is called sausages and feeding. You can see and then you can see the hemorrhages, the cotton wool spots, and the exudates. This is a mild to moderate non-proliferative diabetic retinopathy. But as the disease advances, it spreads from a part of the retina to the whole of the retina. And that is the severe non-proliferative diabetic retinopathy. You can see that now it has involved the entire retina. It is not limited to one area, but it is there in all the four quadrants. These are the hard exudates, the soft exudates, and these are the hemorrhages. So you can see that this तरह जब बीमारी फैलती है, how it spreads. and incapacitates the whole of the retina. The most important cause of loss of vision in type 2 diabetes is diabetic macular edema, where the disease primarily targets the center of the eye, which is responsible for most acute vision. When you are looking at something, you are using your macular area. So unfortunately, it's the macular area which is targeted by the diabetic retinopathy. You can see that in the early stages, this is the macular area, and you have these hard aggregates and hemorrhages. But as the disease spreads, it encompasses the whole of the macular area, and that is known as clinically significant macular edema. Now, that was all about the non-proliferative diabetic retinopathy. When the new blood vessels start developing, then it is called proliferative diabetic retinopathy. And you can see the new vessels, they happen at the level of the optic disc. You can see these chiral ones, the chain, these are the new vessels as compared to the normal vessels. And you can see these fronts, or they happen along the vascular artery, which is called new vessels. Now this is, you can see the optic disc. Can you see these fronts? These are the new vessels at the disc, LVP. And this front here is the LVE, which is along the vascular artery. These thick walls are the veins, and these are the arteries. And then you can see these friable blood vessels, which are the new blood vessels. Now, the new blood vessels, because they are not normal blood vessels, they are liable to rupture, causing hemorrhage. And when the disease advances further, then the sight-threatening changes happen, and that is the advanced diabetic eye disease, which is either due to an incomplete treatment or poor management. And what are the signs of advanced diabetic eye disease? Number one is the hemorrhage. Hemorrhage can happen either behind the vitreous when it is called pre-retinal hemorrhage, or it can happen in the vitreous when it is called intragenous hemorrhage. So hemorrhage happens from rupture of these friable blood vessels of the proliferative diabetic eye disease. And when this blood organizes, it develops into fibrovascular membrane, pulling the retina as its attachment, leading to fractional retinal detachment. You can see this is fractional retinal detachment. And when there is marked ischemia, then the blood vessels also start developing on the eyes, leading to neovascular glaucoma, which is very intractable. Alright, so now we have discussed what is diabetic retinopathy, how it happens, how do we monitor its progress from mild to severe form. We must now develop a management plan. When do we start seeing the diabetics for the retinopathy? So if we examine and we find there's no diabetic retinopathy, then you can see them even once a year. Annual checking is enough. But in mild to moderate cases, between 6 months to a year, they should be checked for their diabetic retinopathy. In severe cases, we need to see them every 4 months. Why? Because the risk of proliferative stage of diabetic retinopathy is high, which means we need to see it and then manage it. In very severe, about 2 to 3 months. In proliferative diabetic retinopathy, the moment we see new vessels on the disc or elsewhere, then the danger is they are going to rupture, causing that hemorrhage, that vitreous hemorrhage which I showed you. So there we need to start the treatment immediately so as to prevent the damage from happening or the bleeding from happening. So how do we now, having discussed how the disease progresses, when do you treat, what is the treatment? The treatment was until a few time ago, it was basically argon laser photocoagulation. You used to burn the retina with the laser so as to decrease the oxygen load on the retina and allow the blood vessels, the abnormal blood vessels to shrink. But the development of, and studies have shown that those who have undergone laser treatment had a 50% decrease of visual loss compared to those who had no treatment. But the advent of intravitreal anti-vascular growth factor has completely altered the entire changed the treatment mechanism because it is far superior to laser. And now these intravitreal anti-VEGFs are injected directly into the vitreous cavity, about 3.5 millimeters from the limbus, and what they do is they block the receptors of the VEGF and they prevent the formation of new blood vessels as well as stabilizing the blood vessels. So these are basically monoclonal antibodies which were initially developed for treatment of cancer. And later on, they found out that they had a very positive effect in formation of the blood vessels. So they are injected in the eye, about 3.5 millimeters from the limbus. The most common ones are the Avastin, Eylea, and Lucentis. So the other treatment options is the use of intravitreal steroids, but we need to be careful about the ocular pressure. The laser treatment still has a role, especially the focal and the grip treatment for the macular edema, as well as the PRP for luminescence. But studies have shown that the intravitreal anti-VEGFs are very effective and they have a far superior results than laser. Now, before I end my talk, I will give you an example of one of my patients. A patient of mine who was about 68 years of age with 25 years of history of diabetes came to me with a sudden loss of vision of his right eye. And he was diagnosed with a case of vitreal hemorrhage, which I showed you. And he was very, very much agonized. saying that डॉक्टर साहब मैं तो 20 साल से शुगर का इलाज कर रहा हूँ लेकिन मेरी आंख को किसी ने इलाज कर दी so nobody bothered to examine his eye and result was he became blind. So the take home message is please have a look at the eye also because you can stop that from happening anywhere in the world. That the patient could have sued those doctors that for 20 years I have been under your treatment and not once did you bother to look at my eye, and today I am blind. So who is responsible? So we as doctors are responsible to check the eyes of our diabetic patients, understanding that we can actually save them. I showed you how we can, by diagnosing them early, using the anti-VEGF and laser therapy, we can actually save a lot of sight. And that is my message today. Thank you.
Thank you, Surgeon Commodore Sunil Sanadani. Ladies and gentlemen, I now